I'm Deb Kimmett, and this is the news brief for July 18th, 2022. In this video, we'll cover the developments that have occurred over the last month that pertain to massage therapists. This month, we'll cover our usual updates on the variants, vaccines, and long COVID, as well as an update on Paxlovid and obtaining COVID treatment. So let's get started. A shout out goes to the Massage Health Practitioners and COVID-19 Facebook group. They provide accurate, evidence-informed info, and I want to credit them for a job well done during the pandemic. They're just one of many sources that I use to gain information for these news briefs. You'll also notice at the bottom of the slides, I have an abbreviated source. The full citation is in the companion PDF file, or what I like to call the show notes. And before we get into topics for today, remember, science changes, so what we know today may not be what we know tomorrow. This means that the information presented here will evolve and change as we learn more. And as usual, there's the disclaimer. The information contained in this news brief is informational only. It's not to be considered as medical advice, nor should it be construed as such. First up is the variant update. I use a COVID David tracker via the CDC, and this is a weekly tracker that shows the variant percentages. Each column represents a week, and each color represents a variant. You can see how the pink BA.2 has shrunk over time, and how BA.5 has grown. As of July 9th, BA.5 is very dominant at 65%. It was about at 55% the week before, with BA2.12.1 at 17.3%. It appears that BA4 is at 16.3%, and it dropped very slightly from last week. So BA.5 is the main story. People were talking about BA.4 and BA.5 as a pair, but with these recent numbers, it's telling us that BA.5 is way more dominant than BA.4. So BA.5 is the focus here. As we've talked about before with viruses, a virus has to be way more transmissible in order for a variant to become dominant. And BA.5 is way more transmissible than its predecessors. Both BA.4 and BA.5 escape immunity, which in English means that 1, the vaccine doesn't work as well, and 2, if you've had COVID before, you can be reinfected with these variants. But if you've been infected with a variant, it's unlikely that you'll be reinfected by that same variant. And currently in the UK, and we have to use the UK's number because the US doesn't keep track of this data, reinfection rates make up around 25% of the total cases there. So if the same is true here, a lot of people are going to or have been reinfected with COVID-19 in the United States. It's still not known yet if BA.4 or BA.5 are more severe. So far, there's no evidence that it's more severe. And the vaccine is expected to protect against severe disease. What we do know is that BA.5 appears to be driving a surge as case numbers are ticking up. And the numbers could actually be much higher than reported because people are testing at home and not reporting, or their cases are mild and they're not reported. Around July 5th, the CDC reported 100,000 new cases per day. Some experts are saying that that could be as high as 1 million or 10 times higher. The good news, though, is that although hospitalizations are rising, they're not spiking like they did with the earlier waves. We have a new variant on the scene, BA.2.75, and that is an Omicron subvariant. But we don't know for sure yet whether it's more transmissible, because it seems to be more transmissible because of how it's behaved in other countries. But we're not sure if it'll cause a wave because it could be stopped by BA.5, which is the most dominant subvariant. And we don't know whether it's more severe. So there's a lot of unknowns here. This subvariant is currently in India, Australia, New Zealand, the UK, and Germany. As of June 14th, there were 2 cases in the US. And that chart I showed you earlier, it's not on it. So there aren't enough cases to be significant. The massage therapist takeaway from all this, we're in a surge, but it hasn't spiked yet. And if you've had COVID before, you can be reinfected with BA.5. For now, we recommend that you keep up with your precautions, mask up, have good ventilation in your space, and keep up with your vaccination and all boosters. We suggest that you regularly get tested, at least with rapid antigen tests, and you may want to require testing on the day of your client's appointment. We also have a Paxlovid update. Last month, we talked about Paxlovid, which is an antiviral treatment for COVID, and a few things have changed. First of all, remember Paxlovid must be taken within 5 days after symptoms begin. Early research is starting to show that Paxlovid doesn't help that much if you've been vaccinated. So the FDA has modified its guidelines a bit. The FDA has authorized Paxlovid for mild to moderate cases. Paxlovid is not appropriate for those who need hospitalization due to severe disease. And it's for anyone aged 12 and over weighing at least 40 kilograms, which is a little over 88 pounds, if they're at high risk of developing severe COVID, meaning that the risk of hospitalization or death is probable. Your massage therapist takeaway is everything I just said, plus always check with your treating clinician to see if it's right for you. Along the same lines with Paxlovid, we have a test to treat update. In April, I talked about a test to treat program where it's a one-stop shop where you can go and get tested, get your diagnosis, and get treatment all in one place. But one of the major roadblocks for expanding these programs was that pharmacists couldn't administer Paxlovid or other COVID treatment without a prescription from a doctor. This month, the FDA came up with a good workaround for that. The FDA says that if you test positive for COVID-19, you should first go to your primary care provider to get Paxlovid if you qualify, and a test to treat center second. But there aren't very many of those test to treat centers around. So those choices may not be available, and because of the short time frame to get the drug, the FDA has announced a third option, should the other options not be available, meaning your local pharmacy. Your local pharmacist, should they choose to participate, is now allowed to prescribe Paxlovid in certain cases. So what are those cases? That the COVID case is mild or moderate. Paxlovid is not appropriate for severe cases. And the patient has to be at high risk of developing severe COVID-19. And the pharmacist has to have enough information to assess your kidney and liver function, potential drug interactions, or if potential drug interactions would require a change in your medication dosage, which means they need all of your health records for the past 12 months, including labs and a list of all your meds, including over-the-counter meds. And they'll refer you back to your primary care provider if they can't tell if you have any problems, if they think you may have problems, or if you actually do have any kidney or liver problems or potential drug interactions. This is a good solution to get people in for treatment, as getting the treatment is time sensitive. The massage therapist takeaway. These slides are also your takeaway. If you fit these criteria and you can't get into a doctor or walk-in clinic to get the prescription, or there's no test to treat facility nearby, this is a good option. And we do have some vaccine updates. For kids, last month I reported that the Pfizer and Moderna vaccines had been approved for the 5 and under set. I also reported that Pfizer had one for kids aged 6 through 17, but that Moderna was awaiting approval for a vaccine for the 6 to 17-year-old age group. Well, Moderna's vaccine did get that approval, so parents and kids have a second vaccine to choose from for that age group. There is a small concern with the Moderna vaccine, which is a risk of myocarditis, which is pretty rare. The CDC said that the risk is reduced when the vaccines are spaced further apart, meaning if they're spaced about 8 weeks apart, then that reduces the risk of myocarditis. Also on the vaccine front, at the end of last month, the FDA announced that boosters this fall will include protection from the BA.4 and BA.5 subvariants. It will only be used as a booster, meaning that those who haven't gotten a vaccine as yet will get the original formula. If you hear the term bivalent vaccine, all that means is that there are two components to the vaccine. In this case, it'll include the original COVID vaccine formula, plus a component tuned to the BA.4 and BA.5 Omicron strains. Both Moderna and Pfizer are developing this new bivalent vaccine already, and Pfizer has announced that they'll be ready to deliver it in early October. Moderna's will be ready a little bit later than that, depending on regulatory requirements. It should also be noted that this process is a bit like developing a flu vaccine. It's hoped that the FDA picked the right strain to include in the vaccines. Only time will tell if they were right. In other booster news, currently, a second booster has only been available for those over 50 or those who are immunocompromised. Because of the rise in cases, the White House is now pushing a plan to get everyone over 12 a second booster. This has to work its way through the regulatory processes of the FDA and the CDC, so keep an eye out for that. The massage therapist takeaway on vaccines. There are now two choices for vaccines for kids. Make sure Moderna's is spaced at least 8 weeks apart. Another booster will be available in the fall, probably in October. It will be bivalent, so it will include a BA.4 and a BA.5 component, plus the original booster formula. A second booster for those who didn't qualify before is coming, and so watch for the new boosters coming up. We know that fully vaccinated and fully boosted people are much less likely to have a severe case of COVID. So if you want them and you can get them, get up to date on your shots. And in other news this last month, there was a recent online study that was reported that was conducted on over 39,000 people who can menstruate and were fully vaccinated with the Pfizer-BioNTech, Moderna, or the Johnson & Johnson vaccines. 42% of those taking the survey reported heavier menstrual bleeding, 14% reported lighter bleeding, and 44% reported no change. And significantly, breakthrough bleeding occurred in those who shouldn't be bleeding. 39% of those on gender-affirming hormone treatments, 71% on long-acting contraceptives, and 66% of postmenopausal women. The caveats to this study are that the participants self-selected, so more who noticed changes may have participated, skewing the numbers upward, and there wasn't a control group. The massage therapist takeaway: knowledge is power, meaning that it's good to know that it's not unusual for the vaccine to lead to temporary changes in menstruation. If you or your clients have regular periods, there should not be a concern unless it's persistent. If you or your client normally don't menstruate, take note, meaning that you should talk to your primary care physician, as this can be an indicator of reproductive system cancers. And in our long COVID update, whenever I've talked about long COVID in the past, or post-acute sequelae of SARS-CoV-2, I've said that the CDC and the World Health Organization have competing definitions of what long COVID is. Having competing definitions has frustrated some, but this month, an article came out saying that it's probably a good thing that it's not clearly defined with causes and symptomology. First, nobody really understands PASC, and to define it at this point would not really be based in science. And as we said in our deep dive on the topic, it's likely to be more than one syndrome because there appear to be many causes. One expert thinks there are at least 10 to 15 causes for PASC. And by defining it too soon, it could harm those who really need the care, meaning that access to care could be compromised for those people. In the good news, bad news department, the bad news is that according to a World Health Organization official, the more times you get COVID, the higher the risk of getting long COVID. And because the virus is always changing, you can get reinfected multiple times because you don't build any resistance or immunity to COVID, which again will up your chances of getting PASC. In the good news department, the more vaccine doses you have, the lower your risk for getting long COVID. We'll look at the particulars in a moment. I want to discuss the study itself. This is according to a study involving healthcare workers in Italy. Data was collected for 2 years starting in March 2020, which means that it covered a wide range of variants from the first COVID strain through the Delta and Omicron or BA.1 waves. That's important because it included all of these different strains and Omicron too. And it should also be noted that this was PASC or long COVID that developed after a mild or moderate case of COVID, as those who were hospitalized were excluded from the study. That's also significant because we're not looking at severe cases at all. So let's take a look at the numbers. If you weren't vaccinated at all, your risk of getting long COVID was 41.8%. That's pretty high. It drops if you've gotten at least one vaccination to 30%. If you've had the second shot, then your risk drops even further to 17.4%. And if you've gotten a third shot, it drops down to 16%. At this point in the study didn't go long enough to encompass that fourth shot yet. So that information is not included. The massage therapist takeaway from all this, there's still no clear definition of PASC or long COVID, and that could be a good thing for now. While the numbers of cases and hospitalizations are ticking up, following our precautions of masking and ventilation along with keeping up vaccinations is very important to lower the risk of long COVID. This is due to the more times you're reinfected, which is possible because you can be reinfected with a different variant each time, the higher your risk of long COVID. And the more doses you've had of the vaccine, the lower your risk of long COVID or PASC. So keep up those precautions. And our final topic has to do with long COVID mortality rate. A question was submitted last month which asked how many people die of long COVID, and I thought that this would be a good time to discuss that. The short answer is we don't know. I found a few articles on this, and I'm going to go through them in date order because when information is released is just as important as what information is released. The closest we come to current real data was outlined in an article in Politico that appeared in June. In that article, a branch of the CDC, the National Center for Health Statistics, has started to look at about 100 death certificates from 2020 and 2021 that, quote, could be attributed to long COVID, unquote. There are several problems with trying to nail down an answer to the question, and this article from June outlined some of those problems. First, we don't know if those people had underlying health conditions. We don't know whether long COVID was the cause of death or a contributing factor. We also don't know how to diagnose long COVID because we don't know how to define it. And the CDC has not issued guidance on how to track deaths on death certificates. And in October 2021, that was the first time that there's actually a medical diagnosis code, an ICD-10 code, that could be used to diagnose it and track it. But I think this information from the CDC might turn out to be reliable when they release the full data set. But for now, we're not sure because of all the questions involved. It's just like the beginning of the pandemic. We had a ratio of deaths to the number of cases, and it was quite high. But now that we have vaccinations, that has changed. From there, our data point number 2 comes from an article that showed up in April of 2021. That's over a year ago. There wasn't anything that I could find in between then that seemed reliable. But in April of 2021, a large study of over 74,000 veterans was released. These were COVID survivors who survived at least 30 days after diagnosis and were not hospitalized, compared to 4.9 million vets who did not have COVID and were not hospitalized. About 2.3% of people with COVID died within 6 months compared to 1.4% of those without the virus, which translates to a 59% higher chance. Now, you could look at that and say that this 2.3% could provide a statistic, but there are some problems with that. because this study doesn't include hospitalized people. But that could be problematic because how could you tell if they had long COVID or just simply never recovered from their original bout of the disease? That's another issue. And there's another issue. The COVID group was selected from those with a COVID diagnosis that were diagnosed between March 1st, 2020 and November 30, 2020. The emergency use authorization for the Pfizer vaccine was first approved on December 11th, 2020. So basically, this is an unvaccinated cohort, which could skew the numbers upward. You could also argue that these numbers are pre-Omicron, as the first case of BA.1 occurred in the US in December of 2021. So yes, it could be worse because of Omicron, but the major factor at play here is vaccination. We know from our previous news briefs that vaccinations do a good job of protecting against severe disease and death. So bottom line, these statistics can also present a skewed picture. And finally, our third data point, which was released before the study I just talked about, was a study that was released in January of 2021. It was in the UK and it tracked people who were released from the hospital as of August 31st, 2020. A study found that of those who were discharged from the hospital, 1 in 10 later died. The caution here is that this study only applies to people who were seriously ill enough to be hospitalized, not all long COVID patients. And immediately after this study result was released, critics of the study brought up that very point. Because in general, if someone has been hospitalized, they're, quote, more likely to be readmitted and more likely to die, unquote. Plus again, look at that data collection date. These were people released from the hospital as of August 31st, 2020. So again, this is prior to vaccines, meaning that this data is a little skewed because it was a fully unvaccinated cohort. So just in general, I would caution about any data that was collected prior to vaccines, and I would look at how the data was crunched, as we can see here. At some point, the CDC and its National Center for Health Statistics will come up with some good statistics. But until we have some clear guidelines as to what dying from long COVID means, we're just not going to have good data. And that's your massage therapist takeaway. And that's it for today. Thanks for watching. And again, please remember that science changes. So what we know today may not be what we know tomorrow. Stay safe and be healthy.